So the national program was launched in 2004, and from the beginning we started it as a national program for ART so that we avoid having many bits and pieces of programs that are going on, since this is a small country. But from the beginning we knew that we had to focus on pediatric ART. At that time there were problems because health workers were not comfortable with looking after with providing ART for children. They were saying, what's the point? Let the kids die, the ARVs are toxic, they're just going to make the lives of the children miserable. But despite all that, we just felt like it's unethical not to provide a treatment that is scientifically proven to help to this group of people. So we, from the beginning, decided to have two groups in our program. There was the group which we call pediatric group, and then the adult group. And pediatric was from the age 14 downwards, the adults from 15 upwards, based on the guidance from WHO. In the diagnosis of children, we used to depend on the rapid test and wait actually for the child to reach a certain age before we could decide whether they're actually positive. But when one of our partners supported us with the DNA PCR, we started to test children as early as 6 weeks. And we scaled up this program for early infant diagnosis, trained nurses on collecting dry blood spots, established a system for collecting samples all over the country. Even in rural clinics, we were able to collect samples and then bring back results to the nurses. So this has been a great accomplishment because now we're able to get children as early as less than a month, as early as less than 2 months, to be able to initiate ART from 6 weeks onwards. And at the same time, we realized that yes, we are testing children, but the drugs, the syrups, the caregivers were complaining, the syrups are bulky, you know. An old woman who is looking after a child, a grandchild, would have to bring a basket to collect syrups. But now when we heard from one of our partners who supported us, told us that there's a possibility of fixed dose combination drugs, FDCs, we decided to take it up and start ordering. It also includes pediatric services. So we coupled that with task shifting to make it possible. So nurses at the clinic level have been trained to initiate ART. So this initiation also includes the children less than 15 years old. And this is going on very well. And the nurses are being supported by doctors in this aspect. Yes.
Another accomplishment, I think we haven't had stockouts, and early ART initiation is going well in the country. It is one of our major accomplishments, and the coverage of PIDs that need ART is also a little bit high in the region. Disclosure is still an issue. We have trained nurses on PSS so that we can involve the caregivers on how it's psychosocial support, so that they can be able to initiate the disclosure process as early as possible. And in that category, we do consider the developmental and the maturity of the child. Also, we also have the issue of socio-economic status in the country, because we know with the adherence and everything, you need to have money for transportation, you need the services to be decentralized to your community. We also have issues of overseas and child-headed homes, and we have an issue with policies that are not so clear, because healthcare workers still feel uncomfortable in giving pediatric HIV care and health services, because the policy, they fear there may be legal implications and so on. But we also feel there's still issues in family involvement, and the children are changing a lot of, there are multiple caregivers. It is the maturity and the expansion of the program. We're saying we would want to see less of the under 5s, so that we can focus more on the pre-adolescent and then the adolescent.
Making sure that the children are able to access treatment and all HIV services, including from testing. In fact, even while they're still in the mother's tummy, they can get services closer to their homes in the clinic. So from PMTCT, where we are trying to prevent them from getting infected, into when we offer them the testing services, up to the point where we offer them ART initiation and follow-up of ART. All this is found at the lowest clinic level in the community, which I think is a great achievement in bringing services closer to the people who need the services. Yeah.